Hi, everyone. Welcome to Healthy Hearts. We are glad that you are joining us tonight for this first of 4 virtual seminars we're having during February. As you all know, it's National Heart Month, and we are excited to be able to bring these presentations to you and for all of the people who are helping to make them possible. My name is Megan. I'm going to be the moderator for tonight's seminar. And if you have any questions, we encourage you to use the question and answer section at the bottom of the screen to submit those. Just a few other housekeeping items. This presentation is being recorded, and we will send that link to you if you would like afterwards. It will also be posted later on our Iredell Health System YouTube channel, so you can go back and you can watch this whenever it's convenient for you. You all are on mute tonight, but we do encourage your participation and would encourage you to, again, use that question and answer section at the bottom of your screen to submit any questions you have. Then we'll give those questions to Dr. Martin at the end of this presentation and ask him to answer those for us. So tonight I want to introduce you to Dr. Bradley Martin. He's a cardiologist with Iredell Health System and Statesville Cardiovascular Clinic. He has been a cardiologist for a little more than 10 years now and joined Iredell in August of 2020. He's board certified in internal medicine and cardiovascular medicine and is a member of the National Board of Echocardiography. He currently sees patients in Statesville, Mooresville, and Taylorsville, North Carolina, and is currently accepting new patients. So without further ado, I'm going to hand it over to Dr. Martin to get us started.
All right, thank you very much, Megan, for that kind introduction. I was asked to present a very prudent subject for a lot of folks, especially in this time of COVID-19 and a bit of concern about seeking a medical attention and going to hospitals, but kind of want to cover a 30,000-foot view about symptoms to be concerned about, because in the last year we've recognized that people ignoring symptoms have led to worse outcomes for folks, and we certainly want to give everybody the opportunity to recognize symptoms, because especially for cardiovascular conditions, certain conditions such as myocardial infarctions and stroke require early recognition so that we can get people the best outcomes possible and for good outcomes. So why don't we begin, and we'll be looking forward to some questions here at the end of the talk. And some objectives that I placed for this include just discussing the need to continue to seek medical attention in this time of COVID-19. I'm going to show you some slides regarding the decreased number of folks seeking medical attention in the last year and some of the resultant consequences of that during the COVID-19 pandemic. We at Iredell, and I'm sure at every health system, have taken a large amount of precautions to keep patient safety in mind. And there's good information that people are more likely to develop, to come down with COVID-19 from community spread than they would be from seeking medical attention. So that's certainly important. And then we're going to review the most common urgent cardiac conditions that should be recognized to seek evaluation as quickly as possible, as well as maybe times where they're not as urgent and things that can be followed up with your primary care physician or as an outpatient at our cardiology offices. And we'll certainly have some time for questions at the end. So I do want to cover this first before we get into some of the symptoms and cardiac conditions I want you to be aware of. But there are consequences for not seeking medical attention for urgent cardiac emergencies. Acute coronary syndromes are at the top of that list. These are heart attacks. These certainly require urgent intervention as soon as possible. Minutes matter. These happen when there's obstruction of blood flow to the heart muscle, resulting in cell death and damage to the heart that will have long-term consequences. And there's opportunity to salvage and limit the amount of damage with early recognition and coming to the emergency room as soon as possible so we can get you treated. This will decrease your long-term morbidity and also reduce your risk of death from these conditions. Congestive heart failure is another condition we will cover. This is certainly something that if you ignore the symptoms of, it'll increase your risk of cardiac arrhythmias, sudden cardiac death, and prolonged hospitalization. Cardiac arrhythmia is also something that could be potentially serious, and ignoring symptoms like passing out or syncope could be potentially serious conditions that will elucidate these things and indicate a potential dangerous underlying cardiac condition. So as I touched on in the introduction, trends in seeking emergency room care during the pandemic, we saw very early on in March and April of 2020, there was a huge reduction in the amount of people seeking care in the emergency departments. This was noted in the areas that the pandemic hit the hardest early on, places like Italy and Europe, and then New York City here in the United States in the spring and summer. And there was a lot of concerns about this amongst the medical community, that people weren't seeking medical attention for their chronic medical conditions like hypertension and diabetes, and that by not seeking the attention to these, they would be uncontrolled and lead people at higher risk of things like heart attacks, strokes, and congestive heart failure. This is a graph here that if you look, the yellow and red lines show the incidence of acute heart attacks in 2019 in the yellow line, and in 2020 on the red line. And prior to the beginning of the pandemic, if you look at the bottom, it shows you the time frame in months, and the gray lines when we implemented some of the lockdown situations in early 2020, that the 2019 and 2020 lines pretty much overlapped with some small variations early on in 2020. But once these restrictions became in place and the incidence of COVID-19 increased, which is shown in the blue line, we see that drop off in the 2020 incidence of acute heart attack presentations, which made us wonder, is this truly a something that's just a coincidence, or are people just not seeking medical attention when they're having these serious cardiovascular events? And then I'm showing this is from some data in the UK. The blue line indicating pre-COVID incidence of out-of-hospital cardiac arrests, and the red box showing the incidence of COVID-19 incidence of out-of-hospital cardiac arrests, and then the timeline at the bottom, February of 2020 through May of 2020. And this really concerned us, seeing the almost double the risk of out-of-hospital cardiac arrests in patients in the UK. During the COVID-19 pandemic, and really increasing from February, March, April, and then May being more than almost double the incidence from the previous years. And this is something that medical professionals are very worried about, because we felt people were not seeking medical care, and that this was causing an increase of mortality amongst the community. I posted this. This was kind of a long study, and I just wanted to post the title here and just show that it has been quite well documented here during the pandemic that patients seeking care in emergency rooms don't have a higher risk of contracting COVID-19. And I hope that the gist of what you guys are getting out of this is there's consequences for not seeking medical attention for potentially serious cardiac conditions. COVID-19 has been a, obviously devastating illness that we've all dealt with around the world, but there's still other things going on. People are still having heart attacks. People are still having strokes. People are still having decompensated heart failure, and not managing those conditions for fear of contracting coronavirus is something that are putting people at higher risk. And we at Iredell have done a great job at protecting patients and protecting our staff. And so I want to put everybody's mind at ease that no matter where you are, seeking medical attention if you develop any concerning symptoms to be evaluated is safe to be done in 2021, even during the pandemic. And I'll put a quick plug in to make sure that you sign up for your coronavirus vaccine if you are meeting CDC guidelines. So let's get into the gist of what most people are worried about, or what do I have to worry about? When am I in serious, when are the symptoms serious enough that I need to seek medical attention, and when are things that can wait? And that can be a little bit of a complicated question, but we'll try to kind of go over it and use some common sense ideals to guide when we have to go to the emergency room, call an office to get an urgent appointment, or if things are kind of less concerning. But number one, obviously cardiac arrest. I'm not going to touch much on that. When that happens in the community, generally 911 is being called, someone's being worked on, and that's coming to the ER immediately. But things that can be more subtle are when people are having chest pain syndromes or heart attacks, strokes, decompensated congestive heart failure, and arrhythmias, which can be related to fast heart rhythms, or bradycardia, which are slow heart rhythms, often manifesting itself in passing out type episodes. So let's touch on chest pain first. That's certainly something that gets people the most concerned when they're developing chest pain. I see a lot of patients with chest pain. Most of the chest pain I see is not cardiac. That doesn't mean it should be ignored. There are lots of different types of chest pain. I put this slide in here just to illustrate the complexity of having to tease out what type of chest pain people are having to understand whether some people are having high risk cardiac type chest pain versus other type of chest pains, which can be related to other conditions, tracheal pain or airway pain, pleural pain, which is the lining of the chest, which is often inflamed in times of viruses such as coronavirus, cardiac pain, precordial pain, which is the lining, around the heart sac itself, versus other types of pain like gastrointestinal reflux pain, GERD or heartburn, aortic pain, which is a major blood vessel coming off the heart. So there's a lot of different structures in the chest, and there's a lot of ways that we tease out what we are more concerned about versus what we're not. Certainly in aspects of acute onset chest pain that is persisting, evaluation with things like EKGs, chest x-rays, and other imaging modalities help us differentiate between very concerning surgical type emergencies versus pains related to non-urgent entities. So this is a graph of symptoms of angina. Angina is the medical term for chest pain related to lack of blood flow to the heart muscle. There's two categories for this. There's classical chest pain or angina that we describe as most likely related to heart pain from angina, which is the classical squeezing, heaviness, pressure sensation, people describing an elephant sitting on their chest, burning, radiation to the neck, jaw, shoulder, left arm, although it can be the right arm at some times, or a band-like discomfort. This can be predictable with activity, especially with exercise. Tends to last for a period of time, several minutes of resting, but can last even longer than that. And it often resolves with a stressor being taken away, such as if you're exercising, or if we're giving medications to help increase the blood flow to the heart, such as nitroglycerin or other medications to slow the heart rate. Atypical chest pains, while we say atypical, they can be quite common as the presenting symptom, especially for women and diabetics. Sharp type pain, knife-like pulsating in the chest, random onset, not necessarily with activity, can come and go kind of at any time, last seconds, minutes, hours, or all day. And there may be or may not be resolution of the pain with rest or with nitroglycerin. I would say, here, when we're talking about the types of pains that come and go within seconds, those are generally nothing to be concerned about. Pains that are easily elucidated with movement or reaching with your arms, anything that kind of hurts to touch, generally isn't going to be something to be too worried about in terms of a cardiovascular source, but certainly could be a musculoskeletal issue that you may want to talk to your PCP about. But just a little bit of differentiation. I will say that we get plenty of people having heart attacks with atypical type chest pain. And I often try to tell people, if there's something that's scaring you and persisting for any period of time, to get it evaluated. This slide is showing all the different potential symptoms people may be having related to their chest pain and related to having a heart attack. So this is something called the sensitivity and specificity for males and females. Sensitivity means if people are having this symptom, how often is it going to be related to actually having a heart issue? I would point out that almost all of these numbers are 65% or less, or just a little bit better than a coin flip. And it kind of illustrates that none of these symptoms can you just hang your hat on that, yes, this is a problem, or yes, this is not a problem. It makes it challenging for us as physicians, but even harder for patients that, sweating, people breaking out in a sweat or developing palpitations, chest discomfort, back pain, arm pain. All of these in isolation aren't very sensitive or specific for having a heart attack. Some of the higher numbers you may see in the specificity category, meaning if you're having them, you're likely to be having a problem in the 70s or so. Things like indigestion, palpitations, diaphoresis, and shoulder pain. But again, the sensitivity is very low, meaning if you're having it or not, that doesn't make or break that you're having an actual problem or not. It's highly variable in the way that people manifest their symptoms. I often tell my patients, if I have 20 people in the room with a heart attack, they're all going to give you a little bit of a different story. But the key is that most people end up having a general sense that something is wrong. They're having unrelenting discomfort. And when you add these together, you end up having a much higher predictable problem that you're having an active heart attack. You're having both palpitations with sweating, with shoulder pain and pain going to the neck and shortness of breath. Those coming all together have much more powerful predictive value than just one of them absent other symptoms. So when to make the call. So this is a picture of a patient having what we call a Levine sign. They're kind of clutching their chest and making a fist. That has actually a pretty good predictive value that they're in trouble. And as I mentioned before, any combination of symptoms that lead to a generalized feeling of something is wrong, I have found that is almost universal in patients who have a heart attack. New unfamiliar discomfort or marked worsening of previous experienced pain like GERD. Reflux is a very common issue that people have. I can't tell you how many patients I've seen who presented late with a heart attack, which makes it much harder to treat because they just thought they were having severe experiences of GERD. Almost always they say, well, yeah, this was the worst GERD of my life. This was much worse than what I've recognized, but I thought it was just heartburn. People also say they had felt like it was just pulled a muscle. Generally, pulled muscles would be something that would hurt with movement and activity. Generally, people having heart attacks, movement is not something that worsens their symptom very much. And the other key is to understand your risk factors. You know, are you a healthy 25-year-old with, no risk factors? Your likelihood of having an MI is exceedingly low. It's not zero. But if you're in your 65-year-old male with diabetes and hypertension and your dad had a heart attack and your brothers had a heart attack, you should have a very low threshold if you're having any of these symptoms, whether it's indigestion, shortness of breath, breaking out into a sweat with chest discomfort, to not kind of blame it on something else and to seek medical attention very quickly, because remember, minutes matter and you only have one heart. We'll move on to stroke, which is another emergency that requires very urgent intervention. Strokes can come in different flavors. A stroke is basically a heart attack of your brain. Heart attacks are blood clots that form from cholesterol, plaques that rupture in the heart arteries. There's arteries that feed the brain with blood, and one of those blood vessels become blocked, whether it's from a cholesterol plaque or a blood clot. That area being fed by the bloodstream is no longer getting oxygen, and it manifests itself in a stroke, and that's the most common type of stroke, called an ischemic stroke. There are other types of strokes called hemorrhagic strokes, not as common, but blood vessels that rupture. You've probably heard of aneurysms, or from trauma, people falling, motorcycle accidents, skiing accidents, hitting their head and bleeding to their head can lead to a stroke as well. Symptoms are generally of sudden onset, often unilateral weakness, facial drop, difficulty speaking or slurring words, severe lightheadedness or syncope, vision changes, sudden behavior changes. These are all signs of a possible stroke. Severe headache with nausea and vomiting are typical of high intracranial pressure, which can also be a sign of stroke. Generally, you would have one of the other symptoms from the ischemic stroke category along with those. But these are very important to understand. Oftentimes people say they just weren't able to find the words, or they knew what they wanted to say and couldn't say it. It's very important that these are recognized early because a stroke has a very short window of opportunity for us to treat to minimize the damage to the brain. So, this is a nice little acronym, be fast, as the signs and symptoms to managing a stroke. Recognize headache, dizziness, sudden loss of balance, blurry vision or loss of vision, facial asymmetry with one side of the face. You're unable to blink or smile on one side of the face, or the face is sagging on one side. And then arm or leg weakness on one side of your body, and speech difficulties like we talked about, all being very important manifestations of stroke. Time is critical. You have about a 3-hour window. When you go to the ER, they want to know when was the last time you were normal, because they have a treatment to bust up these clots in your brain. And if you're outside the window, there's no benefit to that. And the damage is kind of done, so to speak. So recognizing these symptoms very quickly, very important in order to receive the fastest treatment to avoid any further damage. All right, congestive heart failure. So this can manifest itself very quickly, although most of the time this is more indolent in the way that it presents. Congestive heart failure, in its broadest sense, is the inability of the heart to effectively circulate blood to the body. And that can be related to blood pressure being out of control. It can be related to arrhythmias or persistent fast heart rhythms. It can be related to injury to the heart muscle from previous heart attacks. And it can also be related to congenital problems with the heart that you're born with, weakening of the heart muscle related to viruses and other congenital conditions. There's different types of heart failure. The systolic heart failure is related to weakening of the heart. And the more common diastolic heart failure, which we're seeing more and more as we live longer and longer, is the heart becoming stiff and unable to relax normally, which is something that we see in this normal aging process in people in their 70s and 80s. And people are living longer and longer. And eventually, if you live long enough, most people will develop symptoms of congestive heart failure. So we'll talk about some of the symptoms here so we can recognize those and get into your primary care cardiologist for evaluation. All right. So this is a nice picture of the heart, just kind of feeling poop there. He's sweating. He's just tired from doing his job. Your heart's got to beat 60, 80 times a minute, every minute of your life. When we get older and the conditions on the heart become challenging, it needs to tune up now and again, just like your car does after it's been on the road for a long time. So the most common symptoms are shortness of breath with activity, shortness of breath laying down in bed, or a condition called orthopnea, waking in the middle of the night feeling short of breath. That's a condition called paroxysmal nocturnal dyspnea. These are common manifestations of congestive heart failure. Lower extremity swelling that persists, rapid weight gain over a period of time in conjunction with the water retention and swelling, new fatigue, poor appetite, persistent cough. I often have patients come see me after they've been treated for multiple rounds of bronchitis or pneumonia over the last several months that never really gets better with antibiotics, and they feel short of breath and with a persistent cough, and it often ends up being congestive heart failure. So this generally is a little bit more indolent. There are certain scenarios that you can develop acute onset shortness of breath where you really feel a sudden onset of work of breathing and like you can't catch your breath. Obviously, those are things that you need to seek immediate medical attention for. But generally, this is a little slower presenting and people notice things over weeks or months. But paying attention and early diagnosis and management gives people better outcomes. And then cardiac arrhythmias. These are times where the electrical system of the heart becomes erratic. It can result in fast heartbeats and people with feeling palpitations, and if uncontrolled and going on for a long period of time, can lead to congestive heart failure. It can also manifest itself in slow heart rhythms. There's a complex signaling in the heart where the impulse that gets the heart to squeeze originates in the top chamber of the heart. It travels down a highway and goes to the bottom chamber of the heart and gets it to squeeze in a coordinated fashion. There's times where that can be blocked and that signal not go the way it's supposed to, and the heart ends up only beating 30 or 40 times a minute, and people feel really short of breath with normal activity because the heart rate doesn't pick up. And it can lead to people blacking out if the electrical impulse pauses. Occasionally, people won't have a heartbeat for 5 or 10 seconds at a time, and that results in severe lightheadedness and blacking out episodes. And those are going to be things that should get your attention. Feeling a palpitation that comes and goes very quickly. I see lots of people with palpitations. Those are a little less concerning. Flip-flop sensation in the chest. These are very, very common. They're very short-lived and just come once in a while. They're generally nothing to be worried about. Transient lightheadedness with a palpitation or bending over. Those are a little less concerning. And symptoms worse with rest and better with physical activity. It's not uncommon to get an extra heartbeat now and again that people feel, and it's often more prevalent when they're resting in bed at night, and they actually feel quite good when they're exercising. And that's a good sign, because if your heart's in trouble, it's always going to tell you when you're exercising that you're in a little bit of trouble. All right. So just to review a little bit, is recognizing potential urgent cardiac conditions quickly is critical for early recognition and treatment to improve outcomes and lower the chance of long-term morbid conditions. Any concerning chest pain symptoms should be taken seriously, especially if you think you have risk factors such as high blood pressure, long-term tobacco use, obesity, poorly controlled hypertension, high cholesterol. and family history of coronary disease. Onset of persistent chest pain should be evaluated as soon as possible by medical professionals, either at an urgent care or an ER. And I would like to remind people that if you're experiencing chest pain and you're concerned it might be your heart, you shouldn't drive yourself. That is something that should be called via EMS, because if you're having a heart condition and you do end up blacking out or having an arrhythmia, obviously you shouldn't be driving a vehicle at that time. Visits with your primary care doctor or cardiologist for any new non-emergent symptoms. It's kind of slowly progressive shortness of breath with activity, palpitations that are fleeting or coming and going, or a racing heartbeat that just happens now and again but doesn't persist for any length of time. These are certainly things that should be evaluated but don't necessarily need to go to the ER. I always try to tell folks, you know, if there's anything scaring you, there's certainly, this is why we're here. But things that are just kind of an annoyance and kind of come and go generally are something that, you know, you don't have to go seek to the ER. Precautions have been taken by the health system to make it safe for people to seek medical care in our local emergency departments and urgent care. So do not let the pandemic dissuade you from seeking urgent medical attention that could save your life. You know, cardiovascular medical conditions are ones that very more so than some other conditions need urgent attention, and putting them off and not seeking urgent attention can be catastrophic to your health. So I just want to remind everybody that if you're experiencing any of these symptoms that you recognize as being high risk, like we discussed, to get yourself to the emergency room. Even if you call us and get us on the phone, we're not going to be able to know what your oxygen level is, what your EKG looks like, what your blood work looks like. And those are all things we have to do to kind of recognize what we have to do for folks. So make sure you're coming to see us so we can take care of you. And with that, I will take any questions if we have any, Megan.
Thank you, Dr. Martin. So just one question it looks like that we had come in. Somebody had asked for clarification on what do you mean when you say PCP?
Yes, very good. Sorry, I shouldn't be using acronyms, but a primary care provider. So whether it's your family practice doctor, your internal medicine doctor, or if you have a nurse practitioner, physician assistant you see as your primary medical provider, you know, again, generally I would want you to interact with them if you're feeling these less concerning symptoms, kind of fleeting symptoms that aren't manifesting themselves in, you know, acute onset chest pain, you know, maybe a fleeting palpitation or feeling a little bit more short of breath with certain activities, but nothing that is causing you to feel acute shortness of breath or that you can't catch your breath. Those would be more urgent, you know, urgent conditions. But there's a variety of things that can cause different conditions, and they can guide you whether they feel you have a pulmonary condition. You know, if you have shortness of breath and you're wheezing, it could be something like asthma or COPD related to tobacco use, just so they can get you to the best provider possible, or a cardiologist if they feel you're having swelling or symptoms worrisome for congestive heart failure. So, you know, interacting with your primary care provider is always important. Obviously, we have people self-refer to us as their cardiologist, and we will interact with your primary care provider so that they know what's going on. So that's, I hope I clarified that.
Great, thank you. Well, if there are no other questions, then we'll go ahead and wrap up. Again, thank you, Dr. Martin, for your time tonight. Thank you, everybody, for attending. As a reminder, there are 3 additional presentations that we'll have throughout the course of February. Please go to our website, iredellhealth.org. So it's iredellhealth.org. Look under our classes and events, and you'll see the other 3 Healthy Hearts seminars that we'll be having, focusing on a variety of topics. We hope you all enjoyed tonight, and we look forward to talking to you again soon. Thank you.